Hello and welcome to this Rural Doctors webcast. I'm Simon Stokes. Thanks for joining us. This program focuses on genetics, and later in the program we'll hear from Julie Ireland from Down Syndrome WA to hear about the support services they offer to families who have a child with Down syndrome and to people who are expecting a baby that might have Down syndrome. We'll also speak with Professor Alan Harvey from UWA about advances in gene therapy and about his own research into gene therapy in neural regeneration. But first, we're joined by the team from Genetic Services of Western Australia, geneticist Dr. Cathie Kirley-Borey, and genetic counsellors Sarah O'Sullivan and Rebecca D'Souza. They spoke to Dr. Olga Ward about genetic factors in cancer and identifying familial cancer risk.
Rebecca, Cathie and Sarah, thank you very much for joining us and welcome to the program.
Thank you. Thanks for having us.
Now, I don't know very much about the Genetic Services Department you're at King Edward's, aren't you?
That's right, yep.
Could you just tell me a little bit about what you do and what your role is in the department?
Yeah, sure. So I'm the Senior Genetic Counsellor at Genetic Services of WA, so we're in Agnes Walsh House just to the left of King Eddie's, and we're set up of 3 different sections. So we've got paediatric, obstetric and so prenatal and adult general, and then we've got the familial cancer program as well.
And I'm one of the clinical geneticists, so I do clinic in the 3 sections that Beck mentioned. I do also outreach clinic. We've got several outreach clinics. I go to Geraldton and Port Hedland.
And I'm a genetic counsellor. I work specifically in the familial cancer program. So as Beck said, there are the 3 different sections of genetic services, but as a genetic counsellor you tend just to work in one at a time. So at the moment it's familial cancer.
Well, familial cancer's been in the news, and the patients, of course, will see Angelina's had her boobs taken off and reconstructed, and they come in and they go, my great aunts and my second cousin once removed had breast cancer, and do I need gene testing? And those patients, they aren't too difficult for a GP to reassure that they've probably just got background population risk. But who should we be red flagging for genetic counselling or for referral?
And Angelina has really impacted our service. I wouldn't have thought that she would have any direct influence on my life, but she really has. So we, at the time when her article came out, we experienced an immediate, I think it was a tripling of referrals at that time, and we now have about a doubling, which is sustained. So it's really interesting that we, I guess, expected that there would be a sharp increase, but that they would drop off. And what we found is that it's quite sustained, that increase. So I mean, it's really good in that she has done what people working in familial cancer have been trying to do in that she's raised awareness. But I guess we weren't quite prepared for the extent of how many more referrals we'd be receiving. And yeah, as you say, for most people it's not going to be the same as for Angelina, in that there is an inherited gene fault that gives them that increased risk of breast and ovarian cancer. So about 95% of cancers are not due to an inherited gene fault. So what we're trying to do is tease out, well, who are those ones in the 5% that perhaps that is the case for them, and there's significantly increased risks of breast ovarian cancer in the case of hereditary breast ovarian cancer, and of course there are other inherited cancer predispositions as well.
So what are they like? What's the list that GPs need to have on their hit list?
I think it's probably fair to say that the big 2 are hereditary breast ovarian cancer, which are associated with the BRCA genes that Angelina has raised the awareness about, and the other one being Lynch syndrome, which was previously known as hereditary non-polyposis colorectal cancer, or HNPCC, and that's associated with an increased risk of bowel cancer and also some others, including endometrial, ovarian, gastric, and to a lesser extent some others as well. So I think in terms of what you're going to see most commonly, it's going to be hereditary breast ovarian cancer and Lynch syndrome.
So Cathie, when some of our patients go and have a colonoscopy or have their bowel cancer resected, they will quite often come back to the GP and say, and the surgeon has recommended that all the immediate members of my family from 10 years younger than I am go and have a colonoscopy. Is that the way we should be should be treating this, or is this just easier to access than gene sequencing a cancer?
It's a good question. So again, bowel cancer is the same as breast cancer. Most of the time bowel cancer happens out of the blue because of a combination of multiple factors, or as new studies have shown, because of bad luck. Mm-hmm. There's been big papers about that. So what we're trying to see is identify people who are more likely to have a genetic predisposition. And you were talking about people having their colon removed or their bowel cancer removed. In Western Australia, most bowel cancer under the age of 60 will be screened for Lynch syndrome. So this is a test that happens on the tumour, so not for the patient. And if that test is suggestive of Lynch syndrome, then people should be referred to us for further discussion. In terms of recommendation for the family, it really depends, what the family is, the age of onset of the bowel cancer, and whether the tumour is suggestive of a possible genetic predisposition.
So if I had a patient who was 48 or 50 and developed a bowel cancer, and because I've never ever had anybody write back to me from the surgical department to say, your patient has a bowel cancer with Lynch syndrome, it's usually just the patient coming back and saying, the doctor said I should get my family screened. Whom should I screen, and how should I screen them, and how should I write the referral, and when do they bounce into your territory rather than just off to the gastroenterologist?
I think there's a couple of parts to that. First of all, if someone's diagnosed at 48, that screening test that Cathie mentioned would happen, and that would give people an increased likelihood or less likelihood of HMPCC or Lynch syndrome being the cause of it. If that showed an increased likelihood, we would be recommending a referral onto genetic service to take that further. And in those the circumstances, once that gets investigated, then surveillance would be recommended from there, because then they would look at testing for the specific gene that showed an increased likelihood. So that screening test that they can do looks at the 4 of the genes that we know can be associated with Lynch syndrome, and then looks at whether they're functioning the way they should. So it's really a screening rather than diagnostic, which is why the surgeon would probably not have that information yet, but that would be the point to refer on to us.
Based on family history, so someone who develops bowel cancer under the age of 50 is someone young, and you would be interested in knowing, is there a family history on both sides of the family? How many people have had bowel cancer? What age were they diagnosed at? Were there other cancer in the family? So we're talking about, red flags before, and that's the main, that's what's really important from the GP, to identify those red flags, like, young people diagnosed with cancer or at a younger age than what you would normally expect. Several people in the family, on the same side of the family, diagnosed with cancer, or someone diagnosed with, more than one cancer. All of these are really elements that would, increase your suspicion that there might be something, a possible genetic predisposition in the family.
Say you find that the person, the person's younger brother who's 38 has the gene, what do you do then?
Well, I guess there's 2 aspects. So there's the patient himself, so the person who has had the gene fault identified. Finding a gene fault is going to give an explanation as to why he developed the cancer at such a young age. And it also tells us about his potential risks for the other cancers that are associated with Lynch syndrome. So we can then provide information and advice on how to manage that risk. And I should probably highlight that we don't actually, we're not the managing doctors, so we provide information, refer on to surgeons, for example, or gastros who would be doing colonoscopies. So we I guess, provide an overview and advice on where to next. So for that, the patient himself, there will also be implications for children. For example, if he had children, each is going to have a 50-50 chance of having inherited the gene from him, and often people do want to know, if they have children, what are the implications. And for the brother that you mentioned, he would then be in the situation of being able to have what we call predictive testing for the gene fault that was identified in his brother. And similar to his brother's children, he's going to have a 50-50 chance of having inherited that fault or not. So gene testing is then going to be very helpful for him, because he's either not going to have inherited it, meaning he's not at increased risk as a result of that gene fault, or if he has inherited it, then there are implications for his health, and he is at potentially increased risk, and he's going to have available to him things that will help to manage that risk.
Yeah, so what are those things? If you've got a person who's at risk, or who's got this little red flag that says, hello, you've got the gene, I take it you've got the gene doesn't mean you've got the disease, it means you've got the gene.
You've got an increased risk. And about, just you've got the gene, it's actually a lot more complex than that, because when we're thinking about genetic testing, we will identify these families where there is a likelihood of having the gene or having a gene change. But the chance of finding a gene change is actually quite small. So we will have families where we can find a gene fault, and that gives us definite information, because we can tell if you've got a BRCA gene fault, you've got an increased risk of breast cancer, you've got an increased risk of ovarian cancer. These are the options. These are the options in terms of surveillance, for example, breast cancer, or prophylactic surgery in terms of ovarian cancer. And we've got quite definite information. But in the majority of families that we see and where we do testing, we actually don't find a gene fault. And that's a bit more complex situation, because we don't know. The technology is constantly improving, but maybe we didn't find something in that gene because it was too complex to be found. There might have been other genes that we don't know about yet, or maybe in that family it was really bad luck.
Yeah. So those patients who've got the close relative at the young age with the cancer, who don't have the identified gene that we have already identified, are they still subject to additional surveillance?
They can be if the picture shows, if we can clinically diagnose, for example, that it looks like there's something, that they're at a high risk still, then there would be surveillance recommended for first and in sometimes second degree relatives. If it looks like it was just an isolated case of a young cancer, then it's less likely to mean ongoing surveillance for other people in the family.
And if we do find a gene mutation or gene change in a family, in someone, and their sister or the brother doesn't have the gene, and there is no other family history, then we can actually be reassuring and say, look, you don't need the colonoscopy from a young age, or you don't need, extra breast surveillance, and you can go back to general population surveillance. So there are situations where actually it does make a significant difference.
So if you came back to the Angelina case, what would you be, say, advising her kids and her siblings?
So in the case of Angelina, we know there's something very definite that we can test for, and again, that's the predictive testing that I mentioned earlier.
And for that type of gene fault, what would her risks have been of getting breast cancer and ovarian cancer?
I believe she had BRCA1.
BRCA1.
Yeah, so we would quote 60 to 80% lifetime risk for breast cancer, and for ovarian up to 50% lifetime risk. So that's looking
really
overall at
yeah.
the lifetime. It's quite significant, yeah. And people, it is though a very subjective thing, and people will interpret those numbers quite differently depending on many factors. Their exposure to people who've been affected, for example. Some people would turn those numbers around and say, well, maybe I've got a 40 or a 50, exactly.
Not getting it.
Yeah. So that is going to influence how people then manage the risk. some people don't want to know if they're at risk. So even if predictive testing is available, some people would elect not to have it. And we would hope that in that situation you assume that you are at increased risk, and so still manage yourself as though that potential risk is there. But you asked about her children and her siblings, so they could have the testing that would say they've either inherited the fault or they have not, meaning if they've not, they're back to general population risk, assuming that there's nothing else going on in the family. And if they have, then they would be deciding which management option was best for them in terms of breast cancer. So there's, as Cathie mentioned, there's a screening approach where you should be having annual surveillance through a specialist service, as opposed to the population risk of when you turn 50, you have a mammogram every 2 years. They would be starting probably from the age of 30, around 30, and having annual surveillance, or they might choose to do what she chose to do, and that's to have the preventative bilateral mastectomies from the breast side of things, and then from the ovarian side of things, the advice would be from around the age of 40 or when you finished having your children, to consider having your ovaries removed, because at the moment, unfortunately, there's no effective ovarian cancer screening. It's not like the breast side of things, where mammograms are actually very good at doing what they're meant to be doing, and that is picking up early breast cancers. From an ovarian point of view, the options are very limited, unfortunately. And I believe she's just been through that surgery very recently.
I suppose from the children's side also, because with BRCA 1 and 2 it's an adult onset condition, we wouldn't be recommending testing in children, because by the time they're adults, who knows what information we will know and what we will be able to offer them. So in the case of BRCA 1 and 2, it is an adult onset condition, so for her children we would be recommending not to do anything until that, or when I
guess also they can make their own mind up
exactly
as to whether
right.
they want to do
Exactly
the
right.
And in fact, we would never offer predictive testing to children unless there were management issue for them.
So is there any genetic tests that you do on children for any particular condition?
Yes, for example, with familial cancer, familial adenomatous polyposis, or FAP, is a condition that can actually present from very early teen, and where surveillance for people who do have the gene change is recommended from about 10 to 12 years of age. So this is one of the conditions where we would actually be offering testing to children and young teenage from about the age of 10 to 12.
I guess that's a counselling issue for you guys, talking to the parents. And
we do get the children in with their parents to discuss these kind of things, and I suppose that's, you know, a big part of our job is making that information easily understood by the various ages of people, and in particular in FAP there's a lot of resources out for talking about FAP to children, given the clinical significance of it. So
I'm guessing that these are children whose parents has had cancer and a pretty significant bowel resection at a very early age?
Or surveillance and surgery at an early age. The kind of background that they're coming from is usually, and their background knowledge is usually different to your average 10-year-old.
It is usually coming at a time of their life where there is a lot going on. It might be, you know, the end of primary school, start of high school, so there is a lot to take into account. So it's really important that they're involved with the process, and it's not just all about the parents. So as Beck was saying, there are appropriate resources out there for them, but it's also important for them to be engaged in the process. And the medical side of things is one bit of it, but then there's also the coping with the result. If it was positive, what would that be like for you? What would it mean? Have you thought about what the result might be? Do you have a feeling one way or another on what you're going to be? Exploring what they know of their families or their parent who's presumably been affected, what they went through. They might be, you know, they might have grown up from a young age knowing a lot about the condition. Other parents might choose to try to shield them in some ways from it, so they might not have the information behind them that we might assume because you grew up with someone. Yeah, so it's really important to have that conversation, find out what their understanding is, do you know why you're here today? You know, tell us what your understanding is and check in with them. So yeah, it's big
And
stuff.
the parent side is often very big because there is a lot of guilt from the parents. So I do find seeing the kids that the kids are often very pragmatic. So it's the main question is, do I need to have a blood test? And that's really, you know, a big thing. And when you say, well, you know, if you don't want to have a blood test, we can do a spit test. And that's often for them.
You can?
Yeah, you can. You can actually. And once you've resolved that, you know, they're often pragmatic, but the parents is a difficult thing, especially if one of the parents does have FAP, because then, you know, you almost have actually, you know, two patients. One is the child and one is the parents, and that's where, you know, the counselling side is really,
and even
really
just
important.
those preconceived notions. So, you know, kids often grow up saying, oh, you're just like your father in this, or you're just like your mother in this, and distinguishing that mannerisms and characteristics are very different to what your genetic build-up is. And just because people have always said you're like dad doesn't mean you've inherited what dad has got. It's kind of fleshing out some of those things so they have a good understanding and as much as possible are informed in the decision they're making, knowing that when they're minors, the parents are doing the decision making as well.
Are there any particular groups of patients that we should maybe be aware of who have a bigger risk of certain genetic conditions? You know, any particular racial background that I could go, gosh, as their GP, I just need to be a bit aware. Is there something?
Not so much in terms of cancer. Certainly in terms of other condition like, you know, thalassemia or cystic fibrosis or things like that.
Though there is the Ashkenazi Jewish
But the Ashkenazi
population.
would be the only one.
So now, do people come in with a little label on them going, hello, I'm an Ashkenazi Jew? How do you pick one? Particularly if they're not doing the religious thing and you're not quite sure.
I think most people have an idea of their ancestry, and
but do they know? Are they aware themselves that they might be at risk of something?
well, I
what are
think
they at risk
there's
of?
pretty good education within the Jewish communities that there are certain genetic conditions that they're more likely to carry a faulty gene. People don't always know though, and much like the family history of cancer, they can only tell us what they do know, and so sometimes we are limited in making the assessment. But if someone comes in clearly and says, you know, my paternal side is of Ashkenazi Jewish ancestry, or Jewish generally, because we do testing for more, certainly in the case of BRCA, there are some faults that are more common in people of Ashkenazi and Sephardic Jewish background, so people don't necessarily know, you know, it's this particular type or this particular type, but if anyone mentions that they have some kind of Jewish ancestry, we would take that into account with our assessment.
And I think we send out family history questionnaires, and especially given, you know, how multicultural Australia is, we will ask about ethnicity, not just where people were born, but ethnicity as well as religious background. So it helps us put the picture together as well. You know, just like there are some Mediterranean genetic predispositions and CF in Anglo-Saxon kind of areas. So we do ask those questions.
Just had a couple of Japanese patients come in asking about gastric cancer,
And
I always thought that was something to do with their load of, well, over the last 20 years, of their load of Helicobacter. But is that also a genetic thing?
there are some, you know, slightly higher risk of gastric cancer in some, you know, in Japanese, for example. It's not quite clear whether it has to do with, you know, Helicobacter or their diet. In some Asian population and as well in some places in South America. There's no specific testing that we offer for them, but for example in terms of recommendation, if there is a family history of gastric cancer and someone has you know, a Japanese or Asian background, we may recommend endoscopies.
Yeah, so in that case it would be clinical surveillance rather than any kind of
Genetic
genetic
testing,
surveillance.
absolutely.
And dear to the heart of all Australians, melanomas. I know that when I've taken a melanoma off somebody, I have to deliver them the unhappy news that they've probably doubled the risk of all of their first-degree relatives just by having their own melanoma. But I'm not really sure whether it's to do just with skin type or whether it's to do with genetics. Can you kind of fill me in a little bit?
Again, melanoma, like any other cancer, if you've got a single melanoma in someone, you know, who has been, you know, exposed to sun, you wouldn't do much about one melanoma. It's when you start seeing, you know, more people in the family, you know, 3 or 4 people in the family who've had melanomas at a young age, someone who gets several melanomas at a young age, these kind of things, which is, you know, I guess out of the ordinary, or more than what you would see in your normal practice. That's when you start thinking, look, there is a bit more than what we would expect just because of the sun and, you know, and things like that.
If it's not in a sun-exposed area of the body, does that?
Exactly the same as well. And, you know, so it's more, I guess, from a GP perspective, that awareness, that things sometimes fall into what you would expect, you know. You know, breast cancer is very common, or, you know, melanoma is not uncommon, but it's when you start seeing things that, you know, add to that.
So if I did have, well, I'm thinking of a recent 25-year-old with a melanoma on his shoulder, do I do anything other than clinical surveillance for his family?
So at the moment, if there was only that, you'd probably recommend clinical surveillance.
But if his brother turns up with one,
and
then I start getting suspicious.
Exactly, especially if the brother is 18 and it's an unexposed area, or, you know, that person gets not 1 but 3 melanomas over a period of time, or, you know, again, 3 or 4 people in the family, that's when, yes, you become more suspicious.
And I guess that's where the family history taking is so important. And as we come from quite a different approach to a GP in that we do see a patient, but in the context of their greater family. And I guess for GPs, limited time, and you're seeing that person for what's going on with them. But for us, it's the family and who has had what kind of cancers at what kind of ages, and not even in an overly detailed way, just to list down, you know, there's a paternal grandfather who had bowel cancer at 48, something like that. We don't need drawn pedigrees or anything like that, which can be hard. As we were talking about, GPs often doing everything online these days, so it's hard for you to, you know, draw out the old style pedigree. So just a list, who has had what. It's also important to know which side of the family, because if you tell us that there's a grandfather and an aunt and they're from other sides, different sides of the family, that's not going to put together the same picture as if everyone's on the maternal side or everyone's affected on the paternal side. So just to say, you know, it's grandfather, paternal, diagnosed at this age, and if there's a few of them, we look at that, and if there's a pattern, we're going to start thinking, this is a bit more than you'd expect in a family. There possibly is something genetic going on. It fits into this pattern. Or, you know, everyone's diagnosed at an elderly age and they're on different sides of the family. It looks like, unfortunately, this family's had more than their fair share of cancer, but there's probably not an underlying genetic predisposition that explains that.
How much would we chase that sort of thing down? Like, you know, the patients often say, oh, I'm not quite sure, but I think Auntie Maud might have had liver cancer, meaning that she's probably had, or bone cancer, meaning that obviously they've had...
That you're not sure the primary.
Probably a primary that's spread from somewhere else.
Again, what kind of cancer, what age? I guess if they tell you Auntie, you know, Amy had cancer in her 80s, you're not going to chase that too much. On the other hand, if they tell you, well, you know, my cousin had breast cancer at 23, that is quite significant. And we don't necessarily ask GPs to chase that information, because that is something we can do. But if you actually identified, well, this is a family where there is a strong history of cancer or cancer at a young age, then what we would suggest, refer the patient on, and then we can actually assess the family history.
Yeah. And do you guys have access to additional information that the general public can't get?
We do, with consent. So there are pathways that we can take that make it a little bit easier for us, but we do still need to get the consent of the people involved. So I was thinking when you were talking about, what do you look for? I suppose there's clusterings, and first degree and second degree relatives makes that clustering a lot more likely to be affecting the person that you're seeing in front of you as well. So we do have ways of getting pathology that make it a little bit easier, but we still need the consent of others. So if GPs are seeing that pattern and then refer people onto us knowing that it does look out of the ordinary, then we can definitely send out things like a family history questionnaire and consent forms to that person, so that we can once they complete it, we can do the homework for them.
I was just going to mention what I think is an excellent resource is for GP, which is called EviQ. This is a website where you can actually find excellent referral guidelines and management guidelines, and it's a national website, and guidelines are constantly updated. So they're a very simple thing about what to look for in a family history and when to refer on, and then very detailed information and presented in very simple ways about how to manage people who, for example, have Lynch syndrome, or someone who's got a BRCA gene fault, and so on.
Just other things that bother patients. Prostate cancer bothers patients. Prostate cancer bothers patients a lot, and GPs will quite often say, we'll see a patient who says, my dad had prostate cancer in his early 50s. His brother had it in his early 60s, and we think Uncle Jim had it when he was 85. And then you don't know whether to is there a gene test or a surveillance test? It's hard enough screening the population.
Again, with prostate cancer, unfortunately, it's very common. So what you're looking for is more than what you're looking at. Young age of onset, how many people in the family. Prostate cancer can be associated, for example, people with a BRCA gene fault. Do you have an increased risk of developing prostate?
So you ask about the sisters then?
So you ask about the whole family on both sides. Again, both sides on the family. A lot of people think that your paternal side is not relevant, but gene, run in both sides of the family. So prostate cancer by itself is a situation where we would rarely offer testing, but if there was a strong family history, for example, of breast cancer or breast and ovarian, sometimes melanoma, can sometimes be associated with Lynch syndrome. Again, it's not a very high risk, but anything more in the family and significant, then again, the idea would be to refer this patient so we can, assess them.
And finally, can you just walk us through the referral process?
Yeah, so there are a number of ways that a referral can be made to us. You can use the central referral service.
So you just write, Dear Genetic Services, please see Jane Bloggs, whose 4 aunts have all had breast cancer before the age of 60.
That would be a very good referral. We'd be very pleased with that. We do always say, I will just throw in here, that if you have any pathology that you can forward to us for your patient, that's always very helpful, because the cancers themselves can tell us a bit about the likelihood of there being a genetic explanation. So grade 3 triple negative breast cancers, for example, that's I guess the classic type of breast cancer that you'd have in a BRCA fault. You can also have that if you don't have a BRCA fault, but that's really important information. Epithelial ovarian cancer, for example, that's another one. So if you've got that, please send it with the referral. But central referral service, that's one option for you. Directly to us, and we can make our details available to you. Or we have a referral form available online, and that asks for more kind of specific information about who's had what kind of cancers. Has anyone in the family been seen anywhere previously? Because that's really helpful. If a cousin or someone has been seen over east or overseas, their genetic service might have done a lot of the background work. They might have done the testing and found a gene fault, so then it's certainly very easy for us.
A lot easier actually. If we know there is a gene fault in the family, you know what to look for, and that makes it quite different.
I just hope you don't find an additional one.
Well, we do have some families where
have more than one.
And it's just a standard referral letter. There's
absolutely.
And the patient, you then send some questionnaires and things out to the patient to fill out?
Usually, yes. So family history is always helpful. So if we can get that in advance of the appointment, that's ideal. For a lot of referrals that we receive, we don't have enough information to know what we can or can't do. Is someone actually at high risk or not? Can we offer genetic testing or not? So we ask them to help us to help them by giving us that family history information. We have a questionnaire that we ask them to complete. And as Beck mentioned previously, we also include consent forms for if there's family members who are not our patients but we need their information to make the assessment. We ask them to pass them on so that we can get their consent to access their records. But sometimes the referral will be quite clear cut. We know this person, regardless of family history, we can offer testing or they're at high risk or whatever the case might be, and then we would be offering them an appointment as soon as possible. Which
how soon is as soon as possible? Is it sort of
yes.
if we're telling the patients, are we telling them, you know, you probably get to see genetic services in 3 months or 6 months, or have you got like a 14-month waiting to wait list?
Within 6 months is probably reasonable, and we do prioritise based on the clinical picture, and if for example someone is very unwell and we want to see them sooner rather than later, if someone's about to start chemotherapy and we need to organise blood because chemotherapy can interfere with the quality of the DNA that we get if we're going to be doing testing, we will prioritise based on a number of those kind of factors. So for someone who is deemed urgent, I would say definitely within the month, if not a couple of weeks.
Does the hospital system refer to you as well?
Yeah, absolutely. Different departments do. And I suppose I was just going to say on waiting lists, it also depends on where people are being seen. So because we do have rural clinics that we do go to, some of those would have longer wait lists or shorter wait lists than
you
others.
said you go to Geraldton and?
Albany, Bunbury, Kalgoorlie, Port Hedland. That's it.
Great. So at least, but you know, at least we've got a few regional hubs
Absolutely.
to which we can refer. Nowhere in the Kimberley?
Not yet. No, Port Hedland is, and we are actually having our first Karatha clinic in June.
So those clinics are held 3 or maybe 4 times each year. So they are generally, you have a longer waiting list just because we don't go there as frequently. Those patients can come to Perth if that's their preference, or often, particularly if people are affected by cancer, they're coming for other reasons anyway. So we can try to coordinate with them if they're coming for surgery or chemotherapy or whatever it is.
Any final words of wisdom for GPs and genetic services?
No, just that if they do have questions, we have email, generic email that they could send us to, and we're happy to answer those as well. And just if they are referring someone, the more information they can give us, the lot easier it makes us to give the accurate information for their patients.
So there's a really good resource for GPs and anyone really to use that allows a relatively quick and easy online assessment of someone's risk of breast ovarian cancer. So it's through Cancer Australia. It's called FRABOC, which is Familial Risk Assessment for Breast and Ovarian Cancer. There's just a couple of questions that you click through, and at the end, when you've put all the information in, it gives you a risk assessment. So is this person at population risk, moderately increased risk, or potentially high risk? And the potentially high risk ones are the ones that we would then see, and a small proportion of those might be eligible within the family for genetic testing to be done. It also gives information about how to manage someone depending on what category they're in.
Again, the EverQ I think is very useful, and then from the GP perspective, just taking a quick family history I think is actually the most useful, and asking both sides of the family what kind of cancer, if known, age at diagnosis, because that already gives you quite a good view of the family history if you can do that.
Thanks to Dr. Cathie Kirrilibori, Sarah O'Sullivan and Rebecca D'Souza for their time today. The various screening and diagnostic tests for Down syndrome can leave a lot of expecting couples worried and confused, and if the initial screening is positive, it's really useful to put families in touch with people who have had that experience themselves. We spoke with Julie Ireland, Family Support Officer at Down Syndrome WA, and herself the mother of a child with Down syndrome, about how she can advise and support parents who are expecting a baby with Down syndrome or are at high risk.
Down Syndrome WA is here because we want to support people when they've had a diagnosis of Down syndrome in their family. So that could be expectant parents, it could be parents who've just had a new baby, or it could be family members or community, and they want to know how to support that family. For new parents, it's about putting them in touch with other people if that's what they want, if they want to discuss some issues. One of our support workers can go to hospital or home and talk to them, answer any of their questions. Often the questions are things like, will my child go to school? Can my child go to a regular kindy? Because you have to put yourself in this family's position. They've just found out something that has altered their life and made them go off in a completely different direction. And so it is a life-changing issue. It is a transition point. It is a point where all sorts of emotions and decisions have to be made. Often it's pointing out to people that what you should do first of all is think about what you would do with any child of this age, and then consider the effect of Down syndrome. But it's not that the Down syndrome itself as such is going to change how you're going to bring up this child, what you're going to do. There are some extra strategies or techniques that might be useful, which we can talk about as we need to. There are some therapies that are suggested to give the child the best chance of improvement and the best opportunities in life. So very often young children will do some physiotherapy. But it's not that you have to do half an hour a day every day. It's the fact that, when you're changing their nappy, you do certain routines and you move muscle groups. So it's a very general, based in the home situation. But I guess for the new parents, it's getting over that initial fear of what they might have to do and what their life might be like. And so if we can give them some examples and help them just come to some sort of a stable path, then that's our role. It's being able to swap experience and learn from people who've been there before and not reinvent the wheel the whole time, because there are options. And sometimes I'll get a question from a parent or even a teacher who says, what should I do about this child? It's a 3-year-old who's got behaviour issues. And you'll look at it and go, well, actually, that's because they're 3. It's got nothing to do with the fact that they've got Down syndrome. You just have to do the usual parenting or behaviour rules or strategies and put all those things in place. You might have to do them for longer for the child with Down syndrome, because it does, I guess the biggest issue is that it takes longer to learn to do everything. So if you keep that in your mind, you might still be having 2-year-old issues when they're 3. So it might take you an extra bit of time to get through that stage of development. But they will get through that stage of development and they will go on and learn to do more things. It just does take them a bit longer to accumulate that and to get that through. There are a couple of organisations that are really important to make sure new parents are linked in with. Obviously us for support if they require whatever they require from us. But there is a WA government organisation, the Disability Services Commission, and people should consider registering their child with that organisation, because they provide at this point in time funded therapy services. So you do get therapy services provided either through therapy groups or through your local hospital in the regional areas. There's a therapy group there that you can access therapy services from. They also provide you with what's called a local area coordinator, who is a person who knows what's in your local area that you can access. So, for instance, I know that in the regional areas there will be therapy services, there will be respite services, there will be all sorts of services that you might use, but I don't know specifically what's in Geraldton or Karratha or whatever. The local area coordinator will. So it's very important to connect in with them so that you know what's in your local area and what's available. One of the other things that's useful for GPs is to know that there are specific growth charts for babies with Down syndrome, because very often if you plot them on the normal regular health lines, they're on the lowest percentiles, and so it's always better to use specific growth charts for children with Down syndrome, because sometimes parents will say, oh, you know, my baby's on the bottom of the scale, and you're not comparing like with like unless you are using those growth charts. So they're always a useful resource, and they're on websites, they're available on websites. One of the important things that often gets missed when parents have a baby with Down syndrome, or they're expecting a baby with Down syndrome, is that nobody actually says congratulations on about having a baby. Sometimes people don't know what to say. And so I think the important thing first off is to welcome the baby into the family and take that from that perspective. But it's also important for GPs to be positive. You know, this is a child, it's a young baby, it's usually someone who's in the family who's wanted, loved, has an auntie, an uncle, a whole family around them. It's not that much different. There are some special things that you might need to consider. There are some therapies you might look at doing. There are some associated medical conditions that you might test for in terms of, you know, heart conditions, and just ruling out some of those major things. But most GPs anywhere are going to see a young child with Down syndrome for the same reasons as they see anyone else. Coughs, colds, cuts, broken arms, life sort of things. Yes, there are some things you need to consider and test for at various stages, and so there are annual health checklists that are available. We do have on our website a new parent kit, so that can be downloaded and given to families, or they can be given information about our website. We do have a prenatal kit that's available through Down Syndrome Australia. So really the main point about having a young child, or a family who has a young child with Down syndrome, a new baby, is to start on the basis that they've got a young child, congratulate them, help them through all of those developmental stages that all children go through, and just look at what that child can do, what their strengths are, what they like to do, and build on those. And then just keep pushing the boundaries as you go. They have Down syndrome, that's their medical diagnosis, but it's not what defines them. They're children first. They just happen to have some things you might have to consider on top of that. And if you treat families in the same sort of way, they're working very hard to get the best for their children, because that's what families want. They want their child to be able to do as much as they can, to be happy, to have a good life, to be responsible. So all those sorts of things that we all want for our children is what the family will be looking for their child with Down syndrome.
Thanks to Julie Ireland from Down Syndrome WA. Finally tonight, Dr Olga Ward met with Professor Alan Harvey from UWA to ask about where we're up to with gene therapy.
Alan, welcome to the program.
Thank you.
Alan, gene therapy sounds like something a little bit science fiction to GPs. And then just recently in Australian Doctor, which is the general practice, general information paper, we see gene therapy being targeted at monogenetic disorders, something called Leber's congenital amaurosis, which I'm presuming you probably know more about than I do. Can you comment, where are we at with gene therapy?
Well, gene therapy is an idea that's been around for a long time.
Yeah.
And in the 1990s, there were a couple of clinical trials that were begun that were probably, the field now thinks were probably done a bit too early. Mm-hmm. So there was actually a couple of complications, and someone died of an immune response, and that set the whole field back a long, long way. Mm-hmm. And this is a common thing when you do translational stuff. If you go too early, sometimes it can backfire on you. So it's taken really 10 or 15 years, I think, for gene therapy to get back into most people's vision again, if you like. Yeah. So this particular trial, there are studies in the United States and in the UK, particularly at the Institute of Ophthalmology at Moorfields in London. I was actually there for about 6 weeks last year, so I know the group very well. And basically, these people are blind because they're missing one gene that is needed for making the photopigments in the photoreceptors. Yeah. So if you supply them with the appropriate gene by introducing that gene using a a modified viral vector, which normally will infect the cell and then the gene gets put into the cells. These people were able to start to see again in a limited way. So that trial's been on the way now for, I think, about 3 years, 4 years. There's some suggestion that they may need to alter the protocols a little bit, that the effects are maybe not as long lasting as they would have hoped, but I think that trial is probably one of the best trials around to say that gene therapy is here to stay if you have the right gene to target and you can access those cells in a way that isn't going to damage anything else.
So this is a single sequence on a single gene and you can just simply replace it?
Yep. Yep.
That sounds pretty exciting. Where does that fit in with your research?
Well, I've been doing a lot of work in the retina and also collaborating with Dr. Stuart Hodgetts, who's here in UWA, on spinal cord injury.
Yeah.
So most of our work's been related to trauma, neurotrauma, seeing if we can protect nerve cells, both in terms of improving their survival after they get injured, and then seeing if we can stimulate them to regenerate their nerve fibres.
Yeah. So how would you even start?
Gene therapy in neurotrauma is very much in its infancy, I think. Yeah. In neurodegenerative diseases in general, though, it is being trialled, and there are a lot of people out there thinking that gene therapy might be a very useful way of improving nerve cell survival in people with Parkinson's disease or Alzheimer's disease or Huntington's chorea or motor neuron disease, those sorts of degenerative diseases where if you could selectively put in a gene that would be a survival factor for those cells, then when a diagnosis is made, if it's made early enough, you might be able to protect the rest of the cells and stop them from dying, and then you basically may have a problem, but it's nothing like as bad as it would have become.
What about getting them to regrow?
Well, in degenerative diseases, you don't need to get them to regrow because they're already hooked into the circuits. That's one of the reasons I actually switched to gene therapy maybe 15 years ago. I had been doing a lot of neural transplantation. In fact, when I came back from the States in the early 80s, originally in Adelaide and then here, we were the only group that was doing fetal transplants in the country at that time. So that was using fetal tissue, and there were some trials in the 80s and 90s still ongoing using human fetal material for Parkinson's disease, for example, putting in dopamine cells. But then there were all the ethics issues that came up with the Bush administration and using fetal material meant that the stem cell business came on board. So now everyone's trying to basically do the same experiments or the same trials, but using stem cells, either embryonic stem cells or these fancy things called induced pluripotent stem cells, which are being used in the retina as well, actually, where you basically take any old cell and you redirect it to become
tell it to become a neuron or tell it to become a photoreceptor
in
or
principle,
something.
And that field is moving at a lightning speed, actually, lightning speed. But the problem I had in the nervous system is that I think it's actually better to try and save the cells that are already there rather than replace ones that are missing, because the cells that are already there are already hooked into their complex circuitry that when we were building our brains in the first place.
So that means that you don't have to get them to grow in a particular
direction. Don't have to do anything
direction.
really fancy, you just keep them alive. But if you want to put new cells in, then you're putting new cells into an adult nervous system. They then have to grow processes, find their right contacts, make all the new connections. That's not an easy task at all. So my own view is if you can save what's there, that's actually better than to put new guys in. And that's the case in all clinical medicine. You don't do a heart transplant if you can preserve the health of the heart that's in there. You don't do a kidney transplant if you can preserve the kidney, right? If you can keep it functioning. Transplantation is a last resort. I view stem cells as a last resort clinically.
So tell me about, say, gene therapying a spinal cord injury.
Yeah, well,
what you're doing.
The problem, well, let's step back one thing. A lot of what we're doing in the cord relates to the work we did in the visual system, where we damage the optic nerve in an experimental animal, mostly rats, and then we use a viral vector which has been modified. And remember that these viral vectors, viruses can be nasty beasts, and there are actual viruses that are currently that they're trying to engineer that actually derive from the AIDS virus, for example. So what you don't want to do is to infect someone with something that potentially could make more copies of something that's nasty. So what happens is that the viral vector jockeys, as I call them, they modify the virus. They get rid of all of the genes in that virus that can make more copies. They get rid of all of the genes that cause the disease problem. So all you get is the package just contains what's needed to get into the cell.
Yep. So it just essentially
Incorporate
becomes
the
a
gene.
cellular DNA
It's a Trojan
injector.
horse, basically, but can't make more copies of itself. So it's non-infective, and once it's done its business, that's it. So these are called replication defective vectors. So you're essentially using it as a way of introducing a gene like a Trojan horse into a cell, incorporating that gene sometimes into the DNA. It doesn't have to be. Sometimes it can actually sit outside of the nucleus, but still be enough to make the message to make the protein. So you can use that approach, and we were using it to introduce a particular proteins into the neurons in the retina that project to the brain, damage them, and we're now able to reconnect the retina to the brain using a combination of transplants and gene therapy. And we're getting probably 15% of all of the adult neurons back into the brain, and we know they're making synapses. What we haven't yet done is to get them to make an ordered map that allows the animal to see good
As
vision.
well as
We
it
know they
used
can
to.
see light and dark, but we haven't yet got them to restore the whole connectivity. Anyway, so we know this is a very powerful approach where what we do is modify the neurons that are damaged, right?
Yep.
In the spinal cord, most people have been targeting the injury. So if someone comes in with a C6 or thoracic, cervical or thoracic crush injury, what we know is that initially the damage isn't that bad. Most injuries are crushes or dislocations, and there's a lot of spare tissue. But in the several days after the injury, you get all these secondary injury cascades: inflammation, immunological reaction, loss of all sorts of terrible things happen. So when you look at the cord a week later, it's a nightmare.
Smushed, yeah.
So most of the therapies are designed, now I think a lot of them are designed to try and stop that secondary injury from happening. And I think the next 10 years we're going to have a lot of good ways of doing that. Okay, but there's still damage. And a lot of the gene therapy approaches have been targeting the injury site to try and make that nicer. Our view is that that might not be the optimal approach, because what we're trying to do is to actually engineer the nerve cells that are sending their fibres through the injury site. Because we know in the visual system that works really well, but no one's really done it systematically after spinal cord injury.
So you're trying to get the nerve cell at the top to regrow
So
an
we're
axon
injecting
through.
virus vectors into the corticospinal, the area of the cortex that projects neurons down the spinal cord.
Yep.
And we've got good evidence that we're getting all sorts of lovely sprouting down around the injury site. But because the injury site's so complicated and messy, they're not able to get through. We can see them doing all this sprouting, trying to do stuff, but they just haven't physically got a way through.
So they've got to get through the scar tissue?
So we're
Is that what
currently
you're looking
doing the studies right now, actually with an honours student, where we're combining that gene therapy approach by putting stem cells. I know I was anti-stem cells, but the nice thing about putting these stem cells into the lesion is that it reduces the amount of secondary injury. So what you end up with is a smaller cavity, more spare tissue, more terrain that any nerve fibres that are regenerating can get through from one side to the other. So we think combining this therapy at the cord and then using gene therapy to sort of put the damaged nerve fibres into overdrive, if you like, put them into top gear, really kick them, that we'll get we try and talk about a 1 + 1 = 3 outcome, or preferably 1 + 1 = 11. That would be really nice.
Yeah. So you were talking earlier about having to modify an HIV-like virus so that it would just inject genetic material without reproducing.
Yep.
Now you're talking about stimulating axons, for instance, to grow through damaged tissue. Once they've done all this sprouting,
You want them to
how
stop.
do you stop them from sprouting?
Look, I think it's a real problem. It depends what protein or what molecule you're interested in. If, for example, in Parkinson's disease, where people get L-DOPA,
Yep.
eventually the effect of the L-DOPA starts to get less.
Yes.
And one of the reasons is that the enzyme that turns the L-DOPA into dopamine for some reason gets down-regulated or starts not to work as well. So one of the therapeutic approaches that they're looking at with gene therapy is to engineer the neurons that make dopamine with more of that enzyme that converts L-DOPA into dopamine.
Yep.
There's not a problem there, because as long as that gene is inside the cell and making the appropriate enzyme inside that cell, you can have it on forever. It's
Yes.
the right thing to do. But if you're using gene therapy to introduce a protein, for example, that's secreted, a growth factor that's
Yes.
necessary to make a cell grow, if that protein is secreted out into the surrounding tissues, you have a problem if it's on forever. And we have some evidence to show that the neurons change their shape, their dendritic shape of all of their processes. And we also have evidence that the surrounding tissue, a lot of the genes change their expression. So we've got a study we're currently writing up 1 year after a single delivery of a vector into the retina. And 1 year later, 2/3 of all the genes we looked at in the retina as a whole, which were altered, significantly altered. Now, we don't know whether that's good or bad, but it's clearly something you have to take into consideration if you just leave that gene switched on
Yes.
all the time. Because currently what you do is you use a promoter for that gene that's a very strong one, so you get the maximal hit.
Yep.
What they're now trying to design is promoters that switch the gene on, may be relevant to that particular cell in a particular status, or where you can switch the thing on and off at will, if you
Yes.
can. And there are currently 1 or 2 ways that you can do that. The problem is that most of those ways are immunogenic. That means that what's being used to switch the gene on and off actually will cause an immune response in the host.
Yeah.
So you can't do that clinically. That's a real problem. So my friends in Amsterdam have designed one of these things that actually seems to be immunocloaked, as they call it. So it's invisible. And once those ones are made, it may be possible in humans to be able to use gene therapy with a non-immunogenic promoter that allows you to give the patient, say, some doxycycline that will switch that gene on as long as you want it on,
Yep.
and then take them off the doxycycline and it'll switch that gene off
Switches off.
forever. There's also a whole new technology that your doctors probably won't know anything about, called CRISPR. And I don't really get it either, but it's this very fancy new way of modifying genes inside cells. And a lot of the gene therapy people are thinking that this new technology will allow very subtle control of any new gene you put in. And this is a field that's moving at incredible pace. So I've got a PhD student with someone at the Harry Perkins, she's interested in cancer. Her name's Pilar Blancafor. And she's interested in a particular gene because in cancer cells, this gene gets dysregulated. And what you want to do in cancer cells is to switch it on,
Yep.
which will actually prevent the cells from proliferating. But in the nervous system, the same gene you want to switch off. So what this graduate student is trying to do is a way, using this new technology, that you can either switch the gene on if you want it on, or switch it off if you want it off. And that way you could hit cancer and neurodegeneration with the same tool. That would be kind of sexy if you could do that.
Alan, it sounds incredibly exciting. Just finally, when do you think that any of this stuff is going to become, if not mainstream, at least clinically viable in treating some disorders?
Well, as we said at the beginning, the trials for these monogenetic issues in the retina are already ongoing. Yep. And they're setting up a whole bunch of new trials. There's another retinal disease, blindness, which relates to mitochondria. There's a mitochondrial dysfunction. Mm-hmm. And they've got vectors now, they think they can sort that one. So there'll be several of those coming through in Europe and the United States, I think, in the next 24 months. And the beauty of those is it's very easy to test. You've got blind people, and then you can see if they see or not.
Yep.
And if they can start to see anything, it's wonderful.
Yes.
So those things are coming on stream. There are currently trials for some limited trials that I know of for Alzheimer's and Parkinson's using gene therapy. There are planned trials for motor neuron disease, as far as I understand it. So these things are gradually coming online, and I think, as I said at the beginning, the recognition that you can now use gene therapy in a way that minimises any immunological complications. So the gene that's now, the vector that's now being used is actually called adeno-associated virus. That's what's commonly being used now. And this is a small vector, small virus that is associated with the adenovirus, the cold virus. But this AAV, apparently humans, about 50% of us carry this anyway, or one of the serotypes, and it doesn't cause any disease. It just sort of sits around. So the beauty of that is that you've got a vector that is non-disease causing, has minimal immunological consequences. So that's why it's currently the vector of choice. And the other beauty of it is that it doesn't need, a lot of viruses need cells to be dividing in order for them to put their DNA into the dividing cell, not with AAV. So you can transfect neurons, put new genes into neurons, doesn't matter. So they're designing whole bunches of new ones, and I think 5 to 10 years down the track, it's hard to put a number on it, but there'll be more and more of these trials. And hopefully the public at large will accept the notion that sort of infecting someone with a live virus can be a good thing rather than a potentially dangerous thing. You know the issues that come along with, genetic modification of crops, for example. There's a lot of people out there saying no, 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 no. So to develop that across to human in the clinical sense, using vectors to modify genes in people, we mustn't. The field cannot afford to make any more serious misjudgments or mistakes, because I think that would be a disaster.
And that's all we have time for in this webcast. Thanks to all our guests, and thank you for joining us. Please join us again in August when we'll have a program focusing on opiates. I'll see you then.